Good evening, dear delegates. Good morning and good afternoon for the global audience. On behalf of Penicia Biotech, warm welcome to today's Diabetes and Beyond, the scientific series program from Dakar Alpha, the division of Diabetes and Cardiology of Penicia Biotech. Penicia Biotech is with healthcare and manufacturing and marketing across the globe, the drugs for the chronic diseases, acute conditions, and vaccines for more than 3 decades. We are pioneered in original research molecule, the branded global generics, and many novel drug delivery system drugs we have introduced at the affordable price for the countries like India, Asian countries, and African countries. The contribution of Penicia Biotech to the human being for controlling the disease is very significant in terms of providing the vaccines to the world. The first WP-based hexavalent vaccines is 6. We are a contributor to the government of India, UNICEF and WHO for eradicating polio from country while providing the oral polio vaccines. We are contributed for the cancer patients by research and manufacturing the first nab-paclitaxel nano-albumin bound first global generic for the cancer management. And in diabetes, for last 3 decades, we have first introduced the glycoside, the glycid M molecule for diabetes care. And then onwards, we are with the diabetologist and cardiologist while providing the quality generic medicine for diabetes management and cardiology, cardiac patients management. We are contributing for the academic research, clinical trials continuously with the Indian doctors. Our collaboration with the national and multinational pharmaceutical company is very significant. In these continuations, we are supporting and caring for the patients. At once the beginning of the COVID-19 at the December, and when the first lockdown we experienced in the month of March 2020, Penicia Biotech is a forefront COVID warrior along with the all healthcare professionals while providing and supporting them the life-saving medicine at these doorsteps of the patients. Later on, we have taken up the responsibility to provide them the technology savvy, like the webinars platform for their academics, and this is continuous. And in this, after the storms of the webinar, we are very selective and we are getting the very good response for having the national and international speaker. We are once again welcoming to you all for Diabetes and Beyond, where we are having the today's speaker, Dr. Stefano del Prato, from Italy, and we are having the globally known, both are globally known, and Dr. Nair from India, the cardiologist. We are lucky enough to have our well-known, world-known Dr. Abdul Hamid Zargar, who is going to moderate and chair the today's session. I will introduce our today's speaker. Can you see my slide? Can you see the slide?
Yeah. Yes, sir.
So, let me get an opportunity to introduce Professor Abdul Hamid Zargar, who is an endocrinologist, well-known and always guiding and chairing the various scientific forum in a country and across the globe. He is a member high-powered committee Vision 2035 Health and Medical Education for Government of India. And as looking at the population, the growing aging population and increasing chronic diseases like diabetes and cardiovascular disease. And India is going to overcome the world as the #1 country for having the diabetic disease. And whereas diabetic complication, cardiac complication is the leading cause of death. And Dr. Abdul Hamid Zargar's guidance will definitely help the country in a bigger way. He is the awardee of the Economic Times in 2021, the chair of Independent Ethics Committee at Fortis Hospital. This is a group of hospitals across the country, and his clinical research acumen is really helping while he is chairing the Ethics Committee. Past President of Endocrine Society of India and former member of Medical Council of India. MCI is the governing body which guides and regulates the clinical practices and medical education in the country. is a member of Institute Body of the AIMS. One of the AIMS is the established globally ranked academic institute for the medical education, having more than 8 branches across the country. He is the chairman, Department of Endocrinology, and director and ex-officio secretary to government, Sher-e-Kashmir Institute of Medical Sciences, Srinagar. I request Dr. Professor Abdul Hamid Zargar to take over and introduce today's 2 speakers. Sir, over to you.
Can you unshare and I'll share my slides?
Yes, sir. Yes.
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 Dr. Kunal, thank you so much for your rather exaggerated introduction. I must say, it's an honor and pleasure to be a part of today's meeting with the legend in diabetology, Stefano del Prato being the main speaker, and a very senior cardiac colleague, Nair, being a part of it. Now, when we are talking about the paradigm shift in the management of type 2 diabetes with cardiovascular complications, many people who have been in the field of diabetology for a decade or 2 would not appreciate the significance of the opportunity that DPP4 inhibitors and SGLT2s provided to them. This paradigm shift only would be appreciated by people who have been in the field for decades. The ones who grew with glibenclamide and chloropropamide, I'm sure Del Prato will have a story or 2 in those days-long hypoglycemias with that. And that 2 insulin is lenti-insulin, NPH insulin, and a regular insulin. And what customization would anybody do? 4 molecules had a monopoly on every patient. But today, today's generation of diabetologists and endocrinologists are very fortunate. With these new molecules in the field like DPP4 inhibitors and SGLT2 inhibitors, in the last decade and a half, life has become far more comfortable for doctor as well as patient with coming in of GLP-1 receptor agonists. Now, we look at the epidemiology of the disease, and I've been talking about this epidemic for the last 3-4 decades. I remember, when I was looking at the top line of this slide, burden of diabetes in rural and urban India. I remember the first meeting I was part of with late Professor MMS Ahuja. That time we thought Indian prevalence of rural areas diabetes was 0.6% and the urban areas was 1.5 in adults. And it is not only that we are talking about these numbers getting very high every day. There's some data, there is a global group known as Non-Communicable Diseases Collaboration Group, and I'm sure there are many people from Italy also in this group. We collated some data, and this is being monitored from the Harvard Medical School and Imperial College London. Huge amount of data from us also. If you look at this, what has happened in the last 4 decades, from 1980 till 2014. Just look at it. At India at position number 2, where we thought in 1980, India had 11.9 million diabetics. And in 2014, this number had escalated to 64 million diabetics. Now, it is not only that the numbers have increased. When we are talking about 1980, the epidemiology of the diabetes would be that type 2 diabetes would occur in 40s and 50s. And average life expectancy in India was 55 to 58. So the glycemic burden even on this 12 million people will be for a decade or less than a decade, because 90% of the sickness in the nation would be of communicable diseases. Malaria, tuberculosis, diarrhea, choleras. But if you look at it today, it's not just the 11 million who become 64 million. No. Now, the same disease occurs in 20s and 30s. Now, the same population expects to reach 70s and 80s. So this disease burden is not only in numbers, but the time spent with this glycemic burden is going to be from 3 to 5 decades. So the chances of complications, you can imagine, not only escalating in terms of the number of diabetics, escalating in terms of renal dysfunction, escalating in terms of coronary artery disease, escalating in terms of an eye disease, foot disease, and the escalating costs that a nation like ours can very ill afford. And understandably, if you look at the cardiovascular disease, which in general is a major contributor to death on this globe. Right from the Hafner's data, when he said that presence of diabetes is a cardiovascular disease equivalent. Some people might contest that term today, but you can see that the type 2 diabetics almost, succumb twice to cardiovascular disease than the non-diabetics. And you can see the relative risk of all-cause mortality and relative risk of cardiovascular death, how high it is in patients with diabetes. Is not only when we talk about in terms of what the diabetes as such does to endothelium, whatever the metabolic component of it does to the body. In-depth study in our country showed that 72% people with type 2 diabetes have dyslipidemia. So huge contribution from that. 2/3 of the people with diabetes have essential hypertension, and good number of them are relatively less controlled or uncontrolled. So again, contributes to coronary artery disease. We know every time we make an attempt. This is a legendary data of Wikipedia. Every time you drop a hemoglobin A1C by 1, there's a corroborative reduction in different organ damages, microvascular disease and macrovascular disease. In fact, on the long term, when the latest data from Wikipedia was published, I believe it was in 2008, I think 30 years data, those people who had initially been intensely treated now started showing their cardiovascular benefits. Our eye has got heart failure in the last decade. I still remember, when during ESD in 2015 Stockholm, Amperag was talked about. And, it's sort of as if an SGLT2s are another add-ons to statins. So much cardiovascular benefit. We know, in diabetes, not only insulin resistance or hyperglycemia, concomitant dyslipidemia and hypertension do contribute to so-called ischemic heart disease or coronary artery disease, which in itself has a potential of giving rise to heart failures, but concomitantly also a macropotentiality of a microvascular disease. What is the impact of advanced glycation end products on the myocardium? Concomitant presence of an autonomic dysfunction. And the term that has been coined collectively for that, a diabetic cardiomyopathy and a heart failure, and the new class of drugs that have a huge impact on them. And in fact, when SGLT2s came to the market, we could never believe it, that one day we'll be talking about this class of drugs in heart failure or CKD, with or without diabetes. And that's what, DAPA heart failure showed us that, yes, it strongly contests now to be a strong contestant for management of coronary artery disease and heart failure. And in fact, if we look at the current guidelines of 2021, they have been in vogue for quite a few years now. If a person has an evidence of a coronary artery disease, has evidence of a heart failure and a CKD, now slowly moves towards an SGLT2 inhibitors or GLP-1 receptor agonists. Last decade and a half has shown us so much data on cardiovascular outcome trials. And we have this era of cardiovascular outcome trial is set in with DPP4 inhibitors, TCOS trial, Carolina. We had declared TEMI for saxagliptin. We had a trial for alogliptin. Vildagliptin did not have one. There's some amazing data that recently was published on 17,000 guys, and our speaker of the day has been a part of it, which looks at the cardiovascular safety and heart failure in vildagliptin. So, I think we have some amazing things to happen this evening. We have two amazing speakers. The first speaker is Professor Stefano del Prato, a professor of endocrinology and metabolism and chief of division of diabetes at Pisa, Italy. Incidentally, I have been to Pisa for a Thyroid Association's meeting, I think a decade and a half back. And Del Prato is currently the president of European Association for Study of Diabetes, member of almost all the global. I've actually seen him in all the conferences I visited for a couple of decades, and a reviewer of most of the prestigious journals in endocrinology, right from Diabetes Care to European Journal of Clinical Investigations to Diabetes, Clinical Endocrinology and Metabolism, has more than 600 publications to his credit, and has been a vice president, European Association for Study of Diabetes from 2011 and 2014, president of Italian Society of Diabetes from 2012 and 2014. And our second speaker is Dr. Tiny Nair, a very well-known name. I've heard him many times, an eloquent speaker, Best Doctors Award winner of Kerala in 2006, most inspiring doctor of India, Economic Times, is a reviewer of many journals, has published many books, and has more than 60 papers to his credit. So we start with our first speaker, Stefano Del Prato. And Professor Del Prato is going to talk to us today about the cardiac safety of DPP4 inhibitors in type 2 diabetes mellitus. Focus on vildagliptin. Over to Professor Del Prato.
Thank you so much, Dr. Hamid Zargar. Thank you for your very kind word and very kind introduction, not just in terms of my person, but for setting up the scene for what is going to be the discussion. And it's my privilege and honor to share this discussion together with Professor Tiny Nair. Also allow me to thank Dr. Kunal and Financial Pharmaceutical for this invitation. As we have been commenting before, it is a pleasure to be here, although I would have rather preferred to be visiting you in India. But, we have to be grateful to the technology that allows us to get together in spite of all the pandemic of the COVID-19. And I really hope that things are getting better for you currently. Now, let me try to share my screen and just to go through my presentation. Hold on. Oops. Just 1 second, and I'll be right there. Here we go. Okay. So, yes, I will be dealing with some aspect of vildagliptin, DPP4, and cardiovascular safety. But I think, that in order to really discuss that, we also needed to consider what is the role of the anti-diabetic and anti-hyperglycemic treatment in diabetes, and what is the role of that treatment according to the duration of the disease and the natural history of the disease. So I'll be referring to some data that have been gathered with the result of the verified trial. Now, first of all, let me go on the full screen presentation and to present to you my disclosures, and also with a bit of a disclaimer, because I need to inform you that this present lecture has been put together by myself. It may not necessarily refer or in line with the company. And in terms of the indication, I do recommend you to refer to your local approved indications. Now, Professor Hamid Zargar reminded us about what is the result of one of the major trial in the world of diabetes that has been the UK-PDS, and the lesson that has been derived from the UK-PDS. Now, what you can see in the slide is the most recent analysis of the UK-PDS just appeared on Diabetes Care. And I think, it's very clearly showing what is the importance of early intervention and effective intervention. What you can see here is this green curve here, and blue and red one that correspond to an assumed reduction in glycated hemoglobin of 1% at the time of the diagnosis of diabetes, 5 years after the diagnosis of diabetes, and 10 years after the diagnosis of diabetes. And you can appreciate how with the delay on effective intervention, there is a significantly increase in the burden in terms of all-cause mortality, as well as myocardial infarction. It is sort of amazing that this result had been obtained with the time of the UKPDS. And Professor Hamid Zargar reminded us of the old days when we were just dealing with diabetes with just, very simple drugs. Metformin, sulfonylureas, some NPH insulin, and that was it. And that's actually what has been used in the UKPDS. So if these are the result of the lesson coming from the UKPDS, you can expect even more, given the major changes that we have been observing in terms of the pharmacological armamentarium that we have had lately for the treatment of type 2 diabetes. This is what it was before the end of the past century. And you can see what happened, with the start of a new century, a flourishing of a different treatment. So you do expect that because of these multiple opportunities for treating properly type 2 diabetes, you may have more people achieving good glycemic control, which actually is not really the case. Because if you do superimpose what has been the changing in terms of available drugs for treating diabetes and what happened in terms of glycated hemoglobin or percentage of people achieving good glycemic control, referring to glycemic control with an A1C equal or lower than 7%, during the same time, you can see that very little has happened. Because what it shows here, once again, is that in spite of a multiple potential for treatment of type 2 diabetes, not much an increase was observed in terms of the percentage of people achieving good glycemic control. So what is the reason for this? Now, there is one reason, and one reason is, of course, there is a clinical inertia. Unfortunately, we have to deal with the time that we could dedicate to the people with diabetes, with the system, and so on and so forth. Also, the patients, adhering to the treatment. But also, one thing that's important for us, physicians, for us endocrinologists to keep in mind, is the complexity of the disease. And type 2 diabetes is a very complex condition. I think that you're very familiar with the homonyms of that from Professor De Fronzo. You can see here the pathogenetic mechanism, and more are to come in terms of effects that could really determine the progressive increase in glycemic levels in people with type 2 diabetes. But also what we are learning is that now we have a multiple opportunity to achieve the treatment. And maybe what we need to consider is this complexity of the disease, keeping in mind that early glycemic control may already translate into potential for reducing the cardiovascular burden together with the burden of microvascular complication in these individuals. Let me give you an example. Because if you do consider what is the current guidelines, the global, I would say, guidelines, they do recommend at the time of diagnosis of type 2 diabetes to start with the metformin. And metformin is a sort of a phenomenal drug because it's been around for more than 60 years now, and every day it suggests a new potential mechanism of action or new potential effects. Here you can see it's a very simple representation of the mode of action of metformin. Remind you that the metformin can reduce plasma glucose concentration by mainly reducing hepatic glucose production, by potentially affecting peripheral glucose disposal, and by reducing the glucose utilization by the gut. However, what we have also learned lately is that metformin may act directly at the level of the L cells of the intestine, the cells that are producing GLP-1. And in doing so, they enhance the effect of the GLP-1 in terms of the production, as well as in terms of the sensitizing effect of GLP-1 on the beta cell. So metformin not only exerts a sensitizing effect, but also seems to modify or to increase the availability of GLP-1. And if you consider this, then you can also consider how you may see DPP4 as a major companion for diabetes because it may preserve some of the GLP-1 enhanced secretion as generated by the metformin, and because of that, exert an even better effect in terms of protecting the beta cell. And if it can protect the beta cell, it then can result, you can provide more sustained glycemic control over the time. And because of that, you could expect also to increase the power in terms of reduction of the risk for micro and macrovascular complication. And actually, this was the basis for the hypothesis that we had in the VERIFY trial. The VERIFY trial was a trial that included people with the early diagnosis of type 2 diabetes with a mild glycemic alteration to start with. You can see here that the average A1C in the population that has been enrolled in the VERIFY trials was in the order of 6.5 to 7%. And and these patients have been allocated to two different treatment strategies. The first one was the typical initial monotherapy, starting with metformin, and then adding a DPP4 vildagliptin at the time of failure. And the control group, or the active group, was a group that were early combination of metformin and vildagliptin was implemented. And the trial really had a very simple question. The question was, now, is the combination therapy to start with providing a better outcome in terms of preserving more people with a good glycemic control over the time? Now, this is the result of the main result of the verified trial. You can see here the two curves of this Kaplan-Meier showing what is the rate of a failure in people with initial monotherapy, those starting with just with the metformin in green here, and those with early combination of vildagliptin and metformin. And now you can appreciate by the combination is reducing by half the risk of a failing over the time. And if you want to translate this into time of reduced exposure to chronic hyperglycemia, or if you want, time gained in terms of good glycemic control with the early combination, then what you can calculate here is that with the median initial time to initial treatment failure with the monotherapy, this tends to occur after the initial 36 months, while with the combination, this extended to 62 months, in other words, ensuring an extra 2 years of good glycemic control. There was also another question related to the verify. Is this initial good glycemic control that is provided by the combination therapy sort of preserving later secondary failure? So people that have been failing and by the way, the combination therapy was also shown to preserve the beta cell function, which was another of the goal of the trial. So as I was mentioning, what I wanted also to try to see is to what extent this initial preservation of good glycemic control could also result in a delayed failure, even when people have failed and have been added on with vildagliptin. So now here, what is interesting, because when these people with metformin failed, they received vildagliptin as well. So now we can compare the same cohort of people with the same treatment. Both of them now on metformin plus vildagliptin. And the question is, was the good glycemic control to start with preserving a later failure? And here is the result, and you can appreciate that having had very good glycemic control because of the early combination with vildagliptin and metformin was associated with a 26% reduction in the risk of failing later on, in spite of the fact that the two populations now have both of them on the same kind of treatment, that is metformin and vildagliptin. So these results really supported the hypothesis that starting and dealing with a multiple mechanism of controlling multiple mechanisms of chronic hyperglycemia type 2 diabetes could provide a more sustained glycemic control. And this is also true irrespective of the different subgroups analysis that have been performed. Because you can see here that if this is the overall effect of the combination therapy in terms of the prevention of failure to treatment, you can see that this is perfectly replicated in people with lower or higher A1C to start with, in people with a lower or higher BMI to start with, in the people with a different age at the beginning, and in people with a different gender, and in people with other cardiovascular risk factors, like, for instance, a smoking status. And also, this was true in terms of the race, the geographical distribution, and the kidney function to start with. Even more, the combination treatment was safe in terms of the tolerability, because when you look at in terms of the adverse events, drug-related adverse events, severe adverse events, death or adverse event leading to permanent discontinuation, and you can go through all these lines here, there are no significant difference with the combination therapy started earlier on versus the monocomponent therapy. And this is also true in terms of one other potential, potential concerns with early combination with this, the risk of hypoglycemia. Now you can see that the rate of hypoglycemia was overall very low and was not significantly increased with the early combination. The other important thing for the treatment of people with type 2 diabetes is just to make sure that you do not make them to gain weight. And let me also remind you that hypoglycemia and body weight are also being a risk factor for cardiovascular events in this population. And what you can see here is what we have been observing in the verified in terms of the change over the time in the body weight. And now you can see there was not very much of a difference between the two over these 5 years of the observation of the verified trial. And I think this is an interesting observation, because when we do consider a treatment, it's not just the efficacy that we need to consider, but it's also the ratio between the efficacy and the tolerability. Let me put that in a sort of a visual manner. So you can see efficacy that could be counterbalanced by the degree of the adverse events people could be exposed to. And if you now have a good efficacy, as I showed you, but also you have less impact in terms of the body weight and in terms of risk of hypoglycemia, you can claim that, relatively speaking, efficacy is better, which also has another implication, because you can have efficacious treatment with a low side effects. You can also expect this to translate into better adherence to the treatment, which also can contribute now to the potential of maintaining and ensuring sustained glycemic control. Now, as I mentioned to you, and one of the messages here is that if we do want to achieve good glycemic control, and if good glycemic control to start with is important also, as has been shown in the UK PDS, to contribute to the reducing the risk of cardiovascular events. So combination therapy may be an opportunity, but now I mentioned to you just one combination out of many other different potential combinations. These are the currently available drugs almost all over the world. Now, if you want to try to calculate what could be the potential for the different combination that you can think about, now you can come up with 28 potential different combinations. Now, one point that is important here is there any combination that may provide us with a better outcome or better expectation in terms of reducing cardiovascular risk? And even more, is there a way we can select those combinations? One way that would select a combination is similar to the one I've been discussing with you, discussing the potential of combining metformin and DPP4, because that was based on complementary mechanism of action. Metformin increasing the release of GLP-1, DPP4 protecting that GLP-1. Here, you can also see another potential complementary mechanism of action between DPP4 inhibition, beta-gliptin, for instance, and SGLT2 inhibitors, for the very reason that Professor Hamid Zargar was mentioning before in terms of the cardiorenal protection of the SGLT2. Let me give you an example. Now, what we have been observing with the treatment of the SGLT2 inhibitor is that the SGLT2 inhibitor can be effective in improving glycemic control. And you can see here an example of looking at the effect of saxagliptin, SGLT2 inhibitor, and metformin, or dapagliflozin and metformin. So again, a DPP4 plus metformin and a gliflozin and metformin in terms of glycemic control, in terms of insulin secretion after the ingestion of a mixed meal, and in terms of the glucagon response. And as we know, with the use of an SGLT2 inhibitor, you can have an increase in the glucagon secretion. Now, what you can consider here is that given the mechanism of action of DPP4 acting to the GLP-1, that by combining an SGLT2 and a DPP4, you may expect it to reduce the glucagon response, and because of that, to really improve to a further extent glycemic control. And this is the result of the study. Now you can see here DAPA plus metformin with an increase in the glucagon, which has not been obtained, of course, because of the combination of saxagliptin, DPP4 inhibition, and metformin. Now, when you do combine the three, metformin, DPP4, and SGLT2, you can see that you can maintain the same degree of reduction in insulin secretion. It was mediated by a lower glucose exposure, but even more, that is the use of DPP4 in combination with the SGLT2 is preventing the increase in glucagon. So if you have better insulin to glucagon ratio, you could expect, as indeed was proven, a further improvement in glycemic control, particularly after the ingestion of a meal. So there is a possibility here then to provide a sustained glycemic control with this combination. It has been suggested with the use of this triple combination of metformin, SGLT2 inhibition, and DPP4 inhibitors in people with type 2 diabetes at the time of their diagnosis, as shown in this specific slide here, and showing the effect of the combination of an SGLT2 inhibitor, empagliflozin, a DPP4 inhibitor, linagliptin, versus the individual component, and showing you a greater impact in terms of reduction of glycated hemoglobin and percentage of people achieving the target. So how we can then transfer all this information on potential way we could use our drugs and DPP4 inhibitor in particular and vildagliptin in particular in terms of potential prevention of complication in diabetes. Let me try to take you through a very simple diagram here. So let's assume that this is a patient with a newly diagnosed diabetes. I think that our common goal is to try to prevent as much as possible the development later on of microvascular and macrovascular complication. I would like to suggest to you that if that is the case, we needed to ensure long-term glycemic control. This is the UK PDS lesson. And if you really want to do that, you want to pick up, glucose-lowering agents with low risk of hypoglycemia and body weight gain. And from this point of view, DPP4 inhibitor could represent a good example for that, particularly if they are used in combination with the metformin, as have been suggested by the result of the Verify. And if you have, as I mentioned already to you, efficacy and lower and better tolerability, this may translate into better adherence, less clinical inertia, that will also help to provide sustained long-term glycemic control. And because of that, you can expect that to reduce the risk of microvascular complication. What I would like to imply to you, however, is that by reducing the burden of microvascular complication, this may also translate into reducing the risk of macrovascular complication. And to this extent, the result of Verify can be of great interest. Now, Verify, as I mentioned to you, was comparing early combination of vildagliptin and metformin versus initial metformin combination in monotherapy with metformin. And what you can see here is the accrual of microvascular events, adjudicated events, during the Verify trial. Remember, these are people with a very low cardiovascular risk because these are people with the beginning of their disease. In spite of that, you can see there is an opening up of the curves. And this has been associated with a numerically reduction in the hazard ratio. And I'm saying numerically because we have to admit the number of events is low and there is no statistical power. It's not statistically significant. However, it is maybe suggesting how important it is to improve glycemic control and how the combination of metformin and vildagliptin seems to really allow this in terms of potential reduction of later complications. Although, as I said, small numbers, wide confidence limits, yet a good suggestion that maybe more dedicated studies are required. But even more, this also supports the cardiovascular safety of vildagliptin within the diabetic population. Professor Hamid Zargar already pointed out to you that this study that we have performed a few years ago together with Professor McGuinness. And what we did was to really perform a meta-analysis with including a total of 17,000 people with type 2 diabetes from the different clinical trials using vildagliptin. And you can see here the MACE and the individual component of the MACE to show how in this very large population, close to 9,600 people treated with vildagliptin and close to 8,000 individuals treated with different glucose-lowering agents, there was not very much of a difference. So suggesting that vildagliptin is not different in terms of cardiovascular risk from other glucose-lowering agents, suggesting vildagliptin is safe. And it's safe even when you do consider specific subgroups, which may be of interest, because the same kind of result has been obtained in people in male as well as in female, in younger or older, with a little bit of a trend for a better outcome with people that are younger as opposed to the one who are older. And even more importantly, when you do consider people with high or lower cardiovascular risk, you can see that vildagliptin again turned out to be safe and not really having an effect in terms of the cardiovascular events as compared to other glucose-lowering agents. And even more when you look at people, in studies that are longer than 52 weeks, so allowing a better impact in terms of the vildagliptin. One of the issues that we had with DPP4 with respect to cardiovascular risk was the signal that has been generated by the result of the SAVOR-TIMI of the potential impact of DPP4 in terms of heart failure. And we also been looking at heart failure within this meta-analysis here. And now you can see the data. Overall, very little, but even more, you can see here that in terms of confirmed heart failure, in terms of new onset heart failure, or in terms of hospitalization for heart failure, there was no difference between vildagliptin-treated patients and people treated with other glucose-lowering agents. Now, this analysis was performed in 2015, and I'd like to report an Italian study because the study has been just, reanalyzing all the data on vildagliptin. And you can see here again what has been the result of this study, of this meta-analysis, including a large number of trials using vildagliptin in terms of the risk of major adverse cardiovascular events in people with type 2 diabetes. And I think that I needed to explain to you how this diamond here reflects safety of vildagliptin as compared to other glucose-lowering agents using in these trials here. And even more, this meta-analysis has confirmed the neutral effect of vildagliptin with respect to the heart failure, as is shown very nicely in this slide here. So vildagliptin can be used earlier on in people with a newly diagnosed diabetes, providing and suggesting that this may help in maintaining in combination with metformin with a longer, more sustained glycemic control, but it can be also used in advanced condition, even in people with high cardiovascular risk, as I showed you in this slide here. But even more, in terms of protecting our type 2 diabetic patient from the burden of micro and macrovascular complications, and along with the line of the combination therapy, when we do consider this early treatment, we may also consider trials of drugs that may have ancillary properties on top of the hyperglycemic of the glucose lowering effect. Now, I mentioned DPP4, and I don't need to remind you how DPP4 may have different mechanisms through which they could have an impact in terms of the mechanisms that are the ground, that represent the ground for micro and macrovascular complication, as has been very nicely depicted in this review published by a few years ago by this Italian friends here on diabetes care. But even more, since I mentioned the potential combination of the SGLT2 and DPP4, and since the Dr. Nair is going to exploit the potential cardiorenal effect of the SGLT2, let me remind you what could be another interesting feature of the potential combination of DPP4 and SGLT2, because SGLT2, as you know very well, have been claimed to provide and actually shown to provide potential renal protection. And what I really like to point out to you in this meta-analysis that I was considering 3 major cardiovascular outcome trials using different SGLT2 is that the protection that has been conferred by the use of the SGLT2 is not present only in people with impaired kidney function, with a GFR lower than 60 ml per minute, but even more in people with perfectly normal to GFR to start with. In those individuals, the relative risk reduction is as high as 56%. So suggesting that the combination of drugs that may be effective in terms of glycemic control, that can be tolerated to a good extent, and may also be associated with effects that goes beyond the glycemic control, may translate into a more direct protection of microvascular complication, for instance, impaired kidney function. And since impaired kidney function, low GFR, and microbinuria are independent cardiovascular risk factors, also contribute to prevent the macrovascular complications. So I think that it's important now, and this is my final message, it is not just the molecule itself. The molecule is important, and vildagliptin is a safe molecule. SGLT2 can help and can be used in combination with DPP4 inhibitors, but even more is the strategy that we need to take into consideration in order really to improve what could be the protection for people with type 2 diabetes. And with this, I'll stop here and thank you very much and looking forward for the discussion. Thank you.
Professor Del Prato, it was really a wonderful talk. I cannot help the temptation of making one comment. That first slide about diabetes care, where it shows that UKPDS data, people who were treated in 60s, 70s, and had excellent control intensely, even with those primitive molecules, the benefit continued to accrue. And when you showed this data on verified trial, the two curves are shifting, even though the p-value is 0.19 only. I'm convinced that if you look at the same people a decade or two later, the significance would drop in. And this is relevant for a nation like India, where, coronary artery disease has doubled up in the last couple of decades. Like in the younger days, the all cardiac disease was rheumatic heart disease or congenital heart disease. Now today, everything is coronary artery disease, heart failure. So if we can impact these two areas, and with, in my younger days, I'm sure that with those molecules, if somebody's hemoglobin A1C would be 7.5, we would be delighted. With these newer molecules in younger population, today we're able to have a hemoglobin A1C of 5.8. I saw 3 people today in my clinic whose hemoglobin A1C was 5.4, 5.5 after 10 years of their disease. So, and those things are doable today. Thank you so much for summarizing in such a short time so many things. Now we are going to our other elite speaker, and we are going to have another talk now on unleashing the cardiovascular benefits of dapagliflozin. And I would say harnessing the cardiovascular benefits of dapagliflozin. Over to Professor Tiny Nair. Please take over, sir.
Thank you, Dr. Zargar, and thank you, Dr. Stefano, for that excellent talk. Give me a moment by the time I share my screen. Is my screen visible and am I audible? Screen is visible and audible?
Yes, audible as well as visible.
Thank you. So my disclosures. Roughly about 350 million years ago, life on Earth decided to shift residence. Life on Earth decided to shift residence, and we left those dark sea waters and walked on to land. The reason for moving on from seawater to land was many, including a better environment and, of course, a better food. Now, there was still one problem, and that problem was as we moved away, further and further away from the sea, we needed salt and water. Water was good, but we needed salt, right? So in our quest to get food, the salt that we had in seawater, plenty of them, were quite far away. So on one side, salt water had sodium, and on the other side, we had plenty of food on land. Basically, we had grains, we had vegetables, we had fruits. Now understand that neither fruits or vegetables, none of them have much of inbuilt sodium in it. So in one master stroke, Mother Nature did something that is unusual. The process of evolution linked sodium, understand that, linked sodium with a carbohydrate, glucose, as a receptor complex. So that the moment you get glucose or you reabsorb glucose from your gut or your kidney tubules, you automatically piggyback and reabsorb sodium. So unnecessarily you don't lose sodium because you are far away. So basically the sodium glucose co-transporter development was to see that the body does not lose unnecessary sodium. But over time, we abused the system. We took huge amount of glucose, so that large amount of sodium also got absorbed, so that less sodium was delivered to the macula densa, leading on to an abnormal tubulo-glomerular feedback and the kind of kidney damages that set in. From there, fast forward to 2021, when our ESC Journal of Cardiology wrote this beautiful article in Braunwald's Corner, written by none other than Professor Eugene Braunwald, SGLT2 inhibitors, the statins of the 21st century. But like we said, let us first talk about the elephant in the room. Yes, elephant in the room. And that starts with the declared TB58 trial, where we saw that if we are looking at, for example, hospitalization for heart failure, or a combination of hospitalization, heart failure, plus cardiovascular death, or simply at MACE, we saw significant reduction of event rates, 27% for heart failure hospitalization, 17% for heart failure hospitalization and cardiovascular death, and 7% for MACE. We saw trial after trial. For example, EMPA-REG outcome trial, we saw CANVAS trial showed similar reduction of all three events, telling us that yes, SGLT inhibitors do reduce MACE, heart failure hospitalization, and a combination of heart failure hospitalization and cardiovascular death. And as exactly like Dr. Stefano said, it took some time for us to understand the real benefit of SGLT inhibitors. And they are not diabetes, they are not weight loss, they are not sodium loss, they are not heart, but on the kidneys. So when we looked at the renal progression, we looked at the reduction of GFR or a combination endpoint of reduction of GFR, end-stage renal failure or renal death, the combinations were reduced by what? 40, 30 to 40 to 50% in different trials. And that was truly, truly amazing. And that brought us to SGLT2 inhibitors in heart failure. DAPA-HF, for example, showed a 26% reduction of combination of heart failure hospitalization or cardiovascular death. EMPA-REG trial with empagliflozin showed a 25% relative risk reduction of again heart failure hospitalization, cardiovascular death. So they were effective in whether there was diabetes or no diabetes. Okay, and yes, on top of GDMT, guideline-directed medical therapy. So on top of guideline-directed medical therapy for heart failure, we saw whether there was diabetes or no diabetes, addition of SGLT inhibitors gave us a unique benefit of reduction of primary endpoints of worsening heart failure or cardiovascular death and heart failure hospitalization. Now the CVD real data, it's a huge database of real life, not a randomized trial, but a real life data that showed us that if we look at, for example, death as a primary endpoint, okay, and look at whether the top line was with cardiovascular disease and patients without cardiovascular disease, both showed benefit. You can see that both are on the left of the line of unity. Okay, not just that, look at heart failure plus death. Every component we see is clearly on the left of midline. And the hazard ratios vary between 0.56 and 0.72, significantly better. Okay, so with that background, we need to look at SGLT inhibitors. We are talking here of dapagliflozin in a big picture way. Okay, now let us look first at heart failure. Okay, we know that heart failure has a very unusual natural history. The history of heart failure is, you can see those troughs and drops. They are hospitalization. So the patient is fine, suddenly gets an acute orthopnea, pulmonary edema, goes to the intensive care, is very bad, is treated with IV diuretic supportives, BiPAP. He comes out of it and he is better. Maybe slightly worse than before, but he is better. Till his next hospitalization. So the trajectory of natural history of heart failure is marked by those troughs, which are heart failure hospitalization. That is why we say that if we're looking at any therapy for heart failure, we look at one, the endpoint, death, right? And second, very importantly, those drops or troughs, they are heart failure hospitalizations. So in heart failure trials, we look at combination of both. And if you look at DAPA-HF with dapagliflozin or EMPA-reduced with empagliflozin, we see that both the trials very, very clearly reduce heart failure hospitalization and death, the combination endpoint of these 2 points, right? But then let us go one step back. For example, in our Indian registry, we saw that 70% of our heart failure patients had a history of acute coronary syndrome in the past. Okay, so we are talking about MACE, a adverse coronary event, right? It is there. So we today know that EMPOWER, Canvas, and Declare, all three SGLT inhibitors have shown that they reduce MACE. So we reduce the basic cause that has put them into heart failure. And if we look at a step before, we know that people get acute coronary syndrome because of multiple risk factors. Diabetes, many of them are obese, they have high blood pressure. So if you look at some major risk factors, type 2 diabetes, hypertension, obesity, all three are targeted by SGLT inhibitors. So SGLT inhibitors tackle multiple risk factors at one go, tend to reduce acute coronary syndromes and MACE, and also prevent heart failure, hospitalization, and death. So we are talking about a molecule from the cardiology perspective, which acts when you have multiple risk factors, acts when you have a risk or a development of MACE or an atherosclerotic vascular disease, acts well when you have a patient of mild heart failure who is likely to get hospitalized, or a severe heart failure patient who is progressively going to deteriorate and die. Okay, so fascinating. It's got a pan natural history effect. Now, from that data, I think this is something that all of us know. In the next about 15 minutes or so, what we will do is we will take some areas, because I'm sure all of you who would have listened to dapagliflozin and SGLT inhibitors umpteen number of times. So we will take out something unusual. We'll look at the confusions, okay, that happens in a vague areas, and then try to put in a clarity in those areas so that we have some direction in these areas where physicians tend not to focus on SGLT inhibitors. Here we are talking about dapagliflozin. Point number one is asymptomatic left ventricular dysfunction. Now this has become common because today every hospital has an echocardiogram, and any patient who complains or doesn't complain get an echocardiogram done. Many of them get an echo done for a routine checkup purpose. And the echo shows, let's say, ejection fraction of maybe 45%. And this patient says, the doctor, I'm fine. So the echo report goes into his file, but nothing really much is done about it because he says, doctor, I walk 5 kilometers a day. Asymptomatic left ventricular dysfunction. Understand that SGLT inhibitors today are not just indicated for a symptom. Okay? We prescribe them for improving their survival. Now, if you look into these patients of diabetes and asymptomatic left ventricular dysfunction, this is the data that came in 2018 from the SOLVE prevention. The SOLVE trial is an old trial where 4,200 patients were taken up, 15% were diabetic. And you look into this data very interestingly, you see that here we are looking at death and heart failure hospitalization. The standard heart failure outcomes, death and heart failure hospitalization. The red line is diabetes and the black is non-diabetic. So you see those patients with asymptomatic left ventricular dysfunction, asymptomatic, they were fine. At the end of 4 years, that straight line, about 50% of them had either died or had a heart failure hospitalization. Just think about it. 50% of those who are asymptomatic with LV dysfunction today would end up with either symptomatic heart failure hospitalization or die. Okay, so these are not patients who need to be neglected. So remember, next time you see in your clinic a patient of asymptomatic LV dysfunction who is fine, when the echo shows a poor number of ejection fraction, patient needs SGLT inhibitor, might benefit by an SGLT inhibitor. What about post-MI? We see a lot of patients who are post-MI. They may or may not have LV dysfunction, right? Now understand that when we have, this is a cartoon, it shows that gray area is infarcted myocardium. And the black area is normal. So when the infarcted myocardium is damaged, the rest of the normal myocardium tries to maintain the cardiac output by contracting much more forcefully. And that gives rise to what we call as remodeling, right? We try to prevent remodeling by ACE inhibitors, by beta blockers, right? Now what happens is that there is increase in wall tension of that thinned out damaged area, the gray area. And we know that over time, even when a patient to start with did not have an LV dysfunction, the gray area enlarges. This is what we call as remodeling. Now, myocardial remodeling is extremely common in the background of myocardial infarction. And if we see the declared TINI's recent sub-analysis, when they looked into dapagliflozin and previous history of MI, myocardial infarction, we see something very interesting. And that is here. If you look at the data, that is MACE, cardiovascular death, or MI, or ischemic stroke. The blue line is those with a previous MI, the top set, on DAPA. The red line is placebo. The bottom line, again, is DAPA and placebo, but no previous MI. So patients who had a previous MI, you see there's a significant difference in outcome between DAPA and no DAPA. Okay, and if you look at the statistics, the hazard ratio is 0.84. 0.84. Okay, so which means next time you see a patient who had myocardial infarction in the past, maybe a year back or 2 years back, think about it. Would he benefit by an SGLT inhibitor? Because the SGLT inhibitor would prevent his cardiac remodeling. The third interesting area I'd like you to focus is on early starting. I mean, this is sometimes misses the physician's mind. Look into that. Okay, if you take the data and see those patients who had no heart failure hospitalization in the past, that first set, and had DAPA or placebo, you see that the relative risk reduction is 16%, and absolute risk reduction of 2.1%. Good, so 16% relative risk reduction if there was no previous heart failure hospitalization. Now, if you had heart failure hospitalization, the whole thing changes. If the heart failure hospitalization, the previous one, was more than 12 months earlier, so the patient says that, doctor, I was last hospitalized for heart failure 12 months earlier, and you put him on a dapagliflozin, your relative risk reduction is 28%, with the absolute risk reduction of 4.1%. But if you had put this patient on dapagliflozin within 12 months of the heart failure hospitalization, the benefit would have been 36% relative risk reduction and absolute risk reduction of roughly 10%. So if you put your patient on dapagliflozin very close to his heart failure hospitalization, his chance for next event, a combination of heart failure hospitalization plus cardiovascular death, comes down by 36%, the absolute reduction of 10%. Okay, so ARR of 10 means you are talking about what? A NMT of 10. That is fantastic. Okay, now, so the point is, earlier you start, the better response you get. Now, look into the meta-analysis of EMPEROR-reduced and DAPA-HF. If you look into the data of DAPA-HF and EMPEROR together and look into those who had NYHA class 2, you see that is the benefit. Roughly about HR of 0.67. So 33% risk reduction. In contrast, if your patient were already in class 3 or class 4, the benefit, whatever drug SGLT, use EMPEROR, EMPA or DAPA, it is far less. So it is always prudent that you start your patient on dapagliflozin far earlier in the disease so that you get a benefit far more than starting on a patient who is already in class 3, class 4, dyspneic, orthopneic, and bad. Okay, then the benefit will be far, far less. So start early. Now, from that, we should understand that the effect, how quickly it comes, we call it fast effect. Right. Now, the data analysis shows something very interesting pertaining to heart failure. If you look at the heart failure benefit, you are looking at an x-axis of days. That x-axis is days. You can see 28 is marked there. And if you see the benefit, the blue line, with confidence interval drawn in the red line, the confidence interval top level cuts unity at 28 days. So some people in this entire cohort would start getting their benefit by 28 days of starting therapy. Okay, so at least some people would get a benefit as early as 28 days. That is fascinating. Imagine that you start up therapy and within 28 days, your patient, within a month's time, patient of heart failure would show some data, some benefit. Now, that means start early. As early start, quicker the benefit. So you should start dapagliflozin, SGLT inhibitors as a whole in heart failure right after one heart failure admission and probably as quickly as possible. I think the most important point that we would highlight is the feel-good factor. There are very many medications which don't make the patient feel good. And unless the patient feels better, obviously is not going to take the medication for a long time. And that's our challenge, for example, in patients of hypertension. A patient of hypertension has no symptoms, so he comes and says, Dr. Saab, your drug has given me peak edema, I have some wheezing or I have some fatigue, why should I take it? So do patients of heart failure feel better? If you look at the Kansas City Cardiomyopathy Questionnaire, what we call as KCCQ, TSS stands for Total Symptom Score, we see that those heart failure patients on dapagliflozin had a far better scoring of 6.1 compared to placebo 3.3 in the whole cohort. So yes, they started feeling better. Not only that, if we take patients who had actually improved significantly, whether it is we take it as improvement by more than 5 points or more than 10 points or even 15 points, we see that the blue line favors dapagliflozin on the right. So significant improvement comes symptomatic improvement with dapagliflozin. In contrast, the number of patients who deteriorated as per the KCCQ TSS scoring by more than 5 are significantly lesser in the dapagliflozin group. So more number of patients improve and less number of patients would feel bad when you start dapagliflozin. So this is totally different from the data we talk about. As physicians, we are bothered about, will the patient's survival benefit kick in? Can he avoid hospitalization? The patient asks, will I feel better? Can I go back to my profession? I'm a teacher. Can I go and start teaching? So I think this is extremely important. This component of the data is often missed out. Feel good factor. And that brings us to rhythm. People don't realize that sudden cardiac death is a major problem in heart failure, especially those who have got a milder heart failure. About 40% of patients with class 2 NYHA heart failure die suddenly. While the cardiac death is much lesser when the patient is in class 4. They basically die of progression of pump failure. Right. Now, does dapagliflozin have an effect on sudden cardiac death, ventricular arrhythmias, or resuscitated cardiac arrest? It seems yes, it does. For example, if you look at this data analysis, it shows the blue line of placebo, the blue line of dapagliflozin reduces sudden cardiac arrest, sudden cardiac death, and major ventricular arrhythmias compared to patients who did not receive dapagliflozin with a hazard ratio of 0.79. Okay, that means 21% reduction of sudden cardiac death. And I think that is fascinating again, because many often we send the patient home who is feeling better, and one day he doesn't wake up, sudden cardiac death. And this is one drug, in addition to beta blockers, that prevents sudden cardiac death in the background of heart failure. A small 2-minute on heart rate. So we know that if we look at heart rate at patients who are discharged from hospital after heart failure. Okay, simple parameter. In fact, we are doing a very large cohort trial in India, which is running now, almost ending today, called Millennial Study. We see that when the patient had a discharge heart rate of more than 77 beats per minute or less than 77 beats per minute, makes a huge difference between his outcome on the day of discharge. So heart rate at discharge of a heart failure patient is a very strong predictor of outcome. We're not talking about costly tests like NT-proBNP or even an ejection fraction. We're talking about heart rate. Okay, so heart rate is important. And in fact, the ESC Journal 2015 very clearly shows in this beautiful review article, Dr. Michael Komadjas has said faster heart rate, more heart failure events. It's very, very clear. Now, a trial called REFORM trial, we know the REFORM trial, we're not talking about anything about REFORM trial, but if you look into the data, very interesting, you see that patients on dapagliflozin had a much slowing of heart rate compared to placebo. Okay, so yes, dapagliflozin tends to have a salutary effect on heart rate. In fact, the resting heart rate of the RHR seems to be most prominently reduced in patients who had a baseline faster heart rate. And hold on for a moment, obesity. That brings us to the last focus point of obesity. Understand that when we talk about obesity, a simple obesity, okay, a person stands out in the crowd. Once we thought that obesity is far less common in India, today, 73% of urban Indians are overweight. And about 50% are actually obese, right? And if we look at obesity, we today know that the whole concept has changed. The obese person might be sitting opposite the physician on the opposite side of the table and might be looking very sleepy and quiet and not responding. Okay, but his sympathetic nervous system is running overdrive. Today we know that the pathway is through pro-opiomelanocortin and leptins, which increases tremendously sympathetic nervous system activity, increase in heart rate. Right? You see the connection. You might say, is there a data? Yes, there is data. Today we know that if you look at the obese patients' mean muscle sympathetic nerve activity, or what we call as MSNA, which is a guide to his sympathetic drive, you see compared to lean, their peripheral obesity, their central obesity is here, significantly elevated. So when you see an obese patient sitting opposite to you in your clinic, he actually has a heightened sympathetic drive. That's why we are now talking about institution of beta blockers in these patients and medications that reduce heart rate. And of course, we know that SGLT inhibitors act in central obesity. We are not going into that topic because we don't have time, but that has a salutary effect on central obesity and obviously by reducing heart rate, mean sympathetic nerve activity. Now, so obesity and OSA, increased heart rate, bad prognosis, and SGLT sits there. So all these years, we were looking at obesity, increased heart rate, and bad prognosis there, not looking at the root. And today we know that the root is far deep down, and unless we uproot it with an SGLT inhibition, probably we're not going to get benefit in that whole tree of obesity, OSA, increased heart rate, and the prognosis, the bad prognosis that we all see. Heart failure drug treatment, the Fantastic Four, is the new paradigm where we are talking about beta blockers, SGLT inhibitors, ARNI, and MRI. These four drugs have improved survival and heart failure. That's why we say, whatever be the challenge, see to it that your patient of heart failure, if possible, put them on a beta blocker, SGLT inhibitor, ARNI, and MRA. Diabetic or no diabetic, any heart failure patient needs to go home on these four drugs. Okay, now, hold on for a minute. That is our own data, right? That is, this data comes from the same town from where we come, Trivandrum, our own data set. This was, the whole project was driven by Dr. Harikrishnan, our colleague, and 12 of the hospitals in Trivandrum area joined that, and we are happy that this registry became popular worldwide, and it initially came into the American Heart Journal, subsequently in the European Journal of Heart Failure, Indian Heart Journal, International Journal of Cardiology, and Journal of Cardiac Failure. Okay, we learned a lot of things from the data of Trivandrum Heart Failure Registry, but this was something that trumped us. Okay, in this data set, the y-axis is cumulative mortality, and the x-axis is the day's time. Now, the lower red line is those patients who received guideline-directed medical therapy. See that they have done well. And by guideline-directed medical therapy, we just meant a beta blocker, an ACE inhibitor, and an MRA, just these three. In contrast, patients who didn't get a guideline-directed medical therapy on discharge, just beta blocker, ACE inhibitor, and MRA, they did so bad. In fact, their mortality was 3 times higher. So I think it is the responsibility of all of us to see that at discharge, whether the heart failure patient is feeling better or not, we should check out, have I given them the drugs that will improve their long-term outcome? Beta blockers, ARNI, MRA, and today SGLT inhibitors. But the point is, in our own registry in India, we found that only 24% of patients received this GDMT of just beta blocker, ACE inhibitor, and MRA in our registry. In a state of Kerala where we all boast that our health system is very robust and good, 76% of our patients that discharged from hospital did not receive just this basic 3 therapies. Okay, and today we are talking about 4 drugs. So the question is this: are we barking up the wrong tree? In meetings, we are all talking about big stuff, 4 drugs, but in the real life level, we are unable to do that. So the challenge is that, can you steer that? Now the point is that in India, the challenge is cost, because many of our patients are uninsured, large number of them. In fact, we see here about 60% of them are uninsured, and they have to bear this extra cost of medications. Now that brings us in India a challenge that you should probably pick and choose and see which one to start first, or which one are you going to anyway start for your patient. Between these 4 beta blockers, ACE inhibitors, ARNI, MRA, and SGLT inhibitors. This data set that came in very recently in the ESC journal doesn't really give us a clue, but gives us some way of trying to compare with, for example, the ARNI in Paradigm and dapagliflozin in DAPA-HF. If you see, the group of people who received these drugs, baseline background therapy are almost same. Now look at the cardiovascular death and heart failure hospitalization. So the combined point of cardiovascular death and heart failure hospitalization was reduced by 20% in Paradigm and 25% in DAPA-HF. Understand, they are not head-to-head trials, they are not comparator trials, but the numbers favor dapagliflozin compared to a ARNI-based therapy. Look at heart failure hospitalization. Again, 0.79 for Paradigm, 0.70 for DAPA. So 20% for Paradigm, ARNI, 30% for DAPA. Of course, when you consider cardiovascular death or all-cause death, the numbers are almost similar, 0.8 and 0.85. Okay, they are almost similar. So though this data is not head-to-head, we have some evidence to say that in selected patients, dapagliflozin may be put earlier before you inhibit your patients with RAS inhibition. Ideal would be all 4, right? Okay, but then probably we have to pick and choose in India. Before we end, something very interesting data. Now this data is biomarker-based prediction of incident heart failure in pre-diabetes and diabetes that came in JACC. Now look at this. This is very interesting. Okay, in this data set, they took patients who had high sensitive troponin, but it is just more than 6. Not a troponin level where we say that it has got an acute coronary syndrome, just more than 6. NT-proBNP, more than 125, not even more than 250 or 300, which we say as heart failure. And HSCRP, more than 3. And a simple left ventricular hypertrophy by ECG. So think about it. A troponin which is not in the level of MI or acute coronary syndrome, just more than 6. A proBNP 125, CRP more than 3, and a left ventricular hypertrophy by ECG. And each of these points, they gave 1 point per score. And now if you look into the data, they were all diabetic. If you look into the data, you see that in these patients, if you employ SGLT inhibitors, you reduce the event rates by 45%. This is a statistical analysis, but it is fascinating. So if you take people with diabetes and very basic low level risk of a slightly elevated troponin, slightly elevated NT-proBNP, HSCRP, and left ventricular hypertrophy by ECG, if you put them on an SGLT inhibitors, you gain a lot. So at the end, where are we for India? In conclusion, ladies and gentlemen, we are talking about asymptomatic left ventricular dysfunction. Don't miss it out. Your patient may not have a symptom, but think in your mind, do you need to put them on an SGLT inhibitor? If they're diabetic, yes. If they're not diabetic, still yes. Because these are patients who, in the next 4 years' time, half of them are likely to become symptomatic. Point number 2, post-MI. Post-MI patients tend to have progressive remodeling. And that is one area where they miss out on prescribing SGLT inhibitors, dapagliflozin, if the patient is not a diabetic. Okay, so think about it. Even if a patient is not a diabetic for sure, think about dapagliflozin in your post-MI patients. Earlier the better. If you put your patients when he's in class 2, you get better relief. If you put your patient on a person who has just had a heart failure hospitalization and recovering, the better, rather than waiting for a long time. Patients feel well. I think that is a very important factor. Patient would come and tell you, initially all patients come and tell us, doctor, this is such a costly medication. Next visit, he would say that I would rather take it. You would say, why? Because I feel better. So patients feel better on SGLT inhibitors. Subsets like obese, think about SGLT inhibition. Heart failure, think about SGLT inhibitors. Patients with tachycardia, think about SGLT inhibitors. So these are patients where we should not miss out on SGLT inhibition. SGLT inhibitors, very clearly, the subset analysis shows reduction of sudden cardiac death. So patients who have a higher propensity, we have scorings to tell us who has a tendency for higher sudden cardiac death by either looking at the QT interval or family history of sudden cardiac death or left ventricular hypertrophy. For them, think about SGLT inhibitors, dapagliflozin. And finally, real world challenges are different in every country. I'm sure Professor Stefano will agree that the challenge in India is different from Italy and the rest of Europe and US, because we have to very carefully choose because of the difference in health economics. And that exists, we can't say no to it. So what we want to say is this is where we started, that we try to clear the confusion to direction by lighting up a light bulb. But we think that if the concept goes down well, it'll be not just one enlightened mind, but multiple minds light up together and have an effect on the long-term outcome of cardiovascular scenario and complications in diabetes. Thank you for your time and attention, and I'll give back the screen to Dr. Zargar. Sir.
Dr. Nair, I must tell you, you made an amazing case for dapagliflozin for heart failure, and it would survive any Supreme Court in the world. You gave it in such a tabulated form that nobody would argue it out. If you look at all SGLT2 inhibitors, and you look at their cardiovascular outcome trials, and I'm sure Professor Stefano has been a part of all of them, the patient population was different, 3-point MACE was different, renal parameters were different, but even in the basic cardiovascular outcome trial, there was only one thing consistent: reduction in hospitalization for heart failure. Even in Vertis trial, sotagliflozin, everything totally different, but reduction in heart failure. And DAPA heart failure formalized the concept because it was the first randomized control trial. And not only, it gave a new turn to it because the cardiovascular outcome trials were predominantly meant for safety of the drug in diabetics as mandated by ADA. But here the mandate was as such for heart failure, even in whether with diabetes or non-diabetes. So I think that's amazing. And I think the total shift of management of diabetes is changing and heart failure is changing. We have a lot of questions to handle, so I would request the two elegant speakers to be a little bit brief, one-liners, because we are aware of the fact that we have little time and Dr. Knight might be leaving us in a few minutes. The first question is from Dr. Shashi Bhushan. it will go to Dr. Stephen Del Prato. See, everything cannot be rosy with DPP4 inhibitors. What could be the possible complications or contraindications for DPP4 inhibitors?
You know, one of the features of the DPP4 is to have a very high tolerability. And because of that, there is no formal contraindication for the use of DPP4. Usually when you deal with glucose-lowering agents, you take into consideration what could be the potential, for instance, of the kidney function. But you know, the DPP4 can be reduced to a dose in order not to build up in the blood, although, you know, this is just a matter of building up in the blood, and there is no known direct association between the concentration of the drug in the blood and potential outcome. So it's just a matter not to throw away drugs by keeping the same dose. You just need to cut down the dose according to the GFR. But if you do that, you know, you just provide the same efficacy in terms of the glycemic control, and you do maintain the same very good degree of tolerability. Initially, there was a thought about, you know, potential heart failure, and Dr. Nair is an expert here, you know, and I think actually historically, if you think of this, the DPP4 and sabotemi was instrumental to draw our attention to a condition that was sort of neglected, not because we didn't know it, but because unfortunately we didn't have any good therapeutical approach. So sabotemi raised the issue, and then we had the MPREG raising the attention for a potential opportunity, and now all the things that Dr. Nair so beautifully explained to us. So I think, again, if you consider, going back to my suggestion initially in terms of the combination, you could also combine the DPP4 and SGLT2. You do retain all the effect of the SGLT2 in terms of the protection with respect to the heart failure, and the combination with the DPP4, because of a very good tolerability, is not going to worsen what is the tolerability of SGLT2, and it's going to add on that, you know, a better glycemic effect. So for people with type 2 diabetes, with people with heart failure, with people with cardiovascular disease, it's a combination that you could consider. And I don't know if Dr. Nair agrees or not.
Yeah, what about the chances of pancreatitis? Because, you know, if somebody has a history of pancreatitis, would we be a little bit careful in giving him these drugs?
Yeah, I mean, as you remember, there was an initial concern about the pancreatitis. There was also concern for term of pancreatic cancer. But now we have sabotemi, we have the TICOS, with the Carmelina, with the Carolina. We have all the meta-analysis, and we do not have any strong signal there for increased risk. And actually, it's very difficult to dissect out what is the potential effect of the DPP4 on pancreatitis risk and diabetes itself, because we do know that diabetes and particularly type 2 diabetes is already associated with an increased risk of pancreatitis. So it's a matter of really having a good contact and a good explanation with the person that you want to put on DPP4 and explaining that there is no association, but if there is some signal for, let's say, increased risk of pancreatitis, it's a matter of discussing with the patient.
Absolutely. I still remember, you know, there was a huge editorial written by one Professor Butler on this about a DPP. And, you know, there's an add-on question to this by Dr. V.C. Panda. I'm like, it looks very relevant and obvious question. Do I have to wait for a cardiovascular event in a diabetic to start SGLT2 inhibitors? I'm so like, you know, can't we just treat it as a good oral hypoglycemic agent and believe that is going to give all those cardiovascular benefits that we so amply alluded to? Do we necessarily have to wait for a cardiac event?
See, the point is that if you look into the data, a patient who does not have huge amount of cardiac risk factors, multiple risk factors, SGLT inhibitors are like any other glucose-lowering agents. Now the point is, in India, you should consider that your diabetic patient who sees any one of us, he is asymptomatic. You put him on a very expensive medicine. Now only about, at least in Kerala, I can tell you, less than 28% of patients, only 28% of patients are insured. So rest have to pay from their pocket. They're not going to eat your medication. In contrast, if you write them metformin, they're going to eat it and their HbA1c might come down, right? But the point is, in that group, SGLT inhibitors have not shown much benefit. But the moment you have multiple risk factors accumulating plus an ASCVD, you see the diamond going onto the left. And the moment there's an LV dysfunction kicking in, you see both prevention of heart failure and those with established heart failure have a significant benefit, like Dr. Zargar said. So as heart failure kicks in, you get benefit. Prevention of heart failure, you get benefit. ASCVD, you get benefit. Multiple risk factors, yes. But a diabetic who does not have any target organ damage, no comorbidities, he just walks in, it may not make a difference, number one. And second thing is that the HbA1c reducing ability of an gliflozin per se alone is very low, right? You have to piggyback it to a DPP4 inhibitor or a metformin perhaps.
When we keep the fact in mind that our own INDAB national study showed that 72% of our diabetics, type 2 diabetics, have dyslipidemia, and 2/3 of them have hypertension, and which will be again, very strong and powerful risk factors for coronary artery disease. Would their presence or absence make a difference in decision making vis-a-vis SGLT2 inhibitors, or no, not necessarily?
For me, yes, absolutely. If there are multiple risk factors, they can afford to have an SGLT inhibitor. Obviously, today, we don't even look at metformin, right? We would start first with an SGLT inhibitor because we have very clear evidence of benefit today. And the data, if we say metformin, is not at all strong compared to SGLT inhibitors. So if a patient can afford and he has multiple risk factors, no question, we are going to put him on an SGLT inhibitor.
Tiny Nair, I have you were just now talking about obesity. And how powerful, and Professor Stefano told us, you remember that scale he was showing us, if obesity goes up, hypoglycemia goes up, other benefits go down. I must tell you one statistical fact that, I was just now telling you about this non-communicable disease risk factor collaboration group. This global group also published some data on how world obesity scale has been going in the last half a century. Where India has also gone, and what we showed. If you look back in 1975, and as a nation, in terms of absolute number of obese people, our men and women stood at position number 19, in spite of our population. We were a populous nation then also, in 1975. In position number 19, in 2014, our men, we have the 5th highest number of obese men in the country today, after China, United States, Russia, and Brazil. And low below, if you look at women who were also at position number 19, today we have the 3rd highest population of obese women in the country, after China and United States. We have my point is that creates a cause for shifting more towards SGLT2 inhibitors, as Professor Delpera was talking about verified trial, combining metformin with, vildagliptin. But I'm talking about combining a relatively cheaper, generic DPP4 inhibitor with a metformin. As you're very right, it may not be a powerful thing, may not reduce HbA1c by 1.2, 1.3, 0.6, 0.8, but combining with metformin, and that might make a significant difference. There's another question, from Dr. Bhupender Singh. Now, end-stage kidney disease, or whatever we do, we see a huge amount of kidney disease in the country. And today, literally 45% of kidney disease is because of diabetes. When in younger days, 80% kidney disease would be because of glomerulonephritis, pyelonephritis, polycystic disease of the kidneys. But today, the whole scenario, Western world, more than 65% is because of diabetes. In end-stage kidney disease, how comfortable we would be with DPP4 inhibitors, and if at any stage there was a signal of fluid-retaining state, or with vildagliptin, would you be comfortable with that, Professor?
Yeah, as I said, there is no specific contraindication, because the dose of the DPP4 that you can find in the blood is not necessarily associated. The point is, to which extent you do need to really force or to really push along the glycemic control in these individuals. So the DPP4 can be used. You probably need to cut down to half the dose. In some cases, you need to go down to 25 the dose, and just in order to not exceed what is the circulating concentration of the drugs. But as far as I know, and as far as being reported, although the study that has been performed in people with a very low GFR are limited, we have to admit, but there are data also for vildagliptin in people with very low GFR. There is no specific signal of a concern. Now, the question in these patients is, once again, is really coming up with the right balance between advantages and potential disadvantages. But I don't see any, as far as I know, any specific contraindication. One thing that, if you allow me, however, to add what Dr. Nair has been saying before, I don't want to run into this issue about, metformin yes, metformin not. I know we already, with ASD, already fighting enough with the European Society of Cardiology about that. But I think that we have a different approach here. I think the SGLT2 is a great drug for people with heart failure, with and without diabetes, and there is no doubt of that. But there is a major difference. For the people without diabetes, SGLT2 inhibitor is a drug for the treatment of heart failure. For the people with type 2 diabetes, SGLT2 is a drug to be used with other drugs in order to prevent the risk of of heart failure. Of course, if there is someone with the heart failure, even more. But I think the great potential, and I understand, and I totally agree with you, that there are some economical and financial constraints that we have to deal with. But from a scientific point of view, I think the SGLT2 have the potential for being phenomenal drugs to prevent renal progression. And if you do prevent the worsening of renal function, you do reduce the burden of a very powerful independent cardiovascular risk factor. And even more, as is shown in the CLARE, for instance, you do have a significant impact also on heart failure or risk of hospitalization for heart failure, even in people with a normal GFR to start with. So you bring about what is the impact in terms of renal progression together with prevention of heart failure, and you can easily combine it with a DPP4, with a metformin, according to what is the difference, what does the need, in order to ensure good glycemic control. Because good glycemic control, first of all, remains a major task in order to reduce the burden of microvascular complication. And our patient may not have, may be prevented some cardiovascular events, but we don't want them to go blind. We don't want them to develop, a diabetic foot because of diabetic neuropathy, and so on and so forth. So we need to have a more comprehensive approach when we deal with diabetes, and not just, focus on this drug prevents heart failure, so there's the drug. This is good for heart failure in people without diabetes. In the people with diabetes, I think that we need to have a more comprehensive approach.
I think, we have already surpassed the time, and questions are still cropping in. And Dr. Tiny has another program at 8 o'clock. Tiny, sorry, we had promised you we'll relieve you at 7:30, but I couldn't help it. So many questions are still dropping in here. I must tell you, it was a very wonderful evening and very well spent evening. And I think I learned quite a few things even at this age today. And always an honor to listen to the Professor Stefano del Prato, and that clarity that we got in managing diabetes in the contemporary world. And how I would re-emphasize only one thing before I sign off. That is extremely important to take diabetes seriously right at the beginning, because many times, particularly in the Indian subcontinent, we tend to underestimate it. Mild diabetes, early diabetes, some that is the time when we need to intensely treat, because it is possible. That is the time to prevent some beta cells from apoptosis, because there are some beta cells still which you can protect. This is the time to give an excellent control for a decade or two, because it is possible. Couple of decades later, it may not be possible. If you look at a 35 or 40 years old guy, he's capable of handling hypoglycemia well. Now, if you look at, as Professor very aptly said, reversible suppression of glucagon. I'm just there was a beautiful paper, Stephanie, in Journal of Clinical Endocrinology and Metabolism on vildagliptin in 2009. Now, you give this thing, you give vildagliptin, insulin levels go up, the glucagon goes down. When blood sugar levels start going into the hypoglycemic range, this suppressive effect is gone. In fact, I remember, Roger Unger, way back when I was young, more than 4 decades back, in my own city, in Srinagar, Kashmir, talking about glucagon. He said, someday people will realize diabetes is not only insulin deficiency, it also means hyperglycogonemia. Roger Unger is the guy who discovered glucagon and got a Nobel Prize in 1972. And heart failure, has eluded, as Professor Stephanie very rightly said, one thing that Saver Temi did brought to attention the heart failure and diabetes mellitus. And in fact, Del Prato, when TCOS was published, MSD United States collected many investigators globally in Barcelona. I was taken from here, and one cardiologist, who incidentally happens to be from my hometown only, Professor Upender Kohl. I'm sure Tiny Nair would be knowing him well. And they showed us the raw data in Barcelona. See, there is no heart failure with our drug. There is no pancreatitis. They showed us literally half a decade's data for 3 days to convince us that we will not million the molecule. I think it was wonderful listening to both of you, and amazing. And I'm sure all those people who listen to this program in the evening would have the same feelings as the moderator of the day has. Over to Dr. Kunal.
Very much, sir. Thanks to Dr. Stefano for being here with us for this is a global scientific program. What we see as a whole human body for the diabetic patient is about the insulin resistance, is a glucagon, and it is a glucose control. You have beautifully said that the DPP4 inhibitor, SGLT2, and overall impact on the glucose lowering effect is controlling the patient's all complications. Dr. T. Nair has stated that Fantastic Four, and on the discharge, how many patients are getting that out of Fantastic Four is not there. Therefore, there is a comprehensive treatment is required to control these complications, which is in the diabetes and along with the cardiovascular diseases. And special thanks to Professor Zargar for beautifully chairing the sessions and taking all the questions on behalf of both the speakers and the entire audience. I especially thanks our marketing and sales team, Pallavi and Bhavini, those who are consistently for many days are coordinating and communicating with you to happen this successful. Thanks to Dr. Kundan, who is the head of diabetes divisions, who is supporting on the all scientific support for this session. And our technical expert team, Karthik Vyas, who is for all the seminars to go without any technical glitches and have the fantastic one. And on behalf of Panacea Biotech, we are always there, sir, for more than 3 decades for taking care of the patient and in support of patient. Panacea Biotech is there with all healthcare professionals for providing the scientific platform like this, and hoping that to see you many more times to enlighten our audience across the world. Thank you very much on behalf of Panacea Biotech. Thanks a lot.
Thank you so much.
Thank you. Thank you.
Take care. Bye-bye.